So let's talk about the science behind what we're doing now. And as an indication to everybody that I'm about to geek out in a big way, I'm going to put my geek glasses on. So you have been warned. Again, if you feel like going into a coma, and since this is going to be coming out somewhere around maybe Thanksgiving, maybe a turkey-induced coma, that's okay. The meat of this that I think I want everybody to understand, we've already talked about. Now I want to, if you really want to know about the science behind this and some numbers, we're going to talk about that now. So the first paper I want to look at is called Minimally Interrupted Cardiac Resuscitation by Emergency Medical Services for Out-of-Hospital Cardiac Arrest. This is a paper by Dr. Bobrow and a lot of his colleagues, and this was done out of Arizona, primarily Tucson and Phoenix, the two largest cities, and their fire departments did this study. So let's talk a little bit about what this study was. This was a prospective study. In other words, this is something that they studied. They said, we're going to make this change and we're going to study the results of the change. So a prospective study gives you a higher confidence in the results than a retrospective study. Sometimes retrospective is all you got, but if it's a prospective study, that's even better. This looked at all of the cardiac arrest in those two cities from January 1st, 2005 to November 22nd, 2007. And they did what's called a before and after analysis. So they looked at the cardiac arrest that occurred before they made a change, and then they looked at the cardiac arrest that occurred after they made the change. Well, the change was they switched to this pit crew CPR, and they called it minimally interrupted chest compressions, or minimally interrupted cardiac resuscitation, or MICR. They also talk about this in some other papers, and there are probably 5 or 6 papers this study has spawned, as cardiocerebral resuscitation, or CCR. So that's what they implemented. And what they actually did will look almost identical to, actually, it does almost identical, I'll say, to what we do. So you get on scene, 200 uninterrupted compressions, rhythm check, shock, go right back without doing a pulse check after shock to another 200 cycle, repeating that cycle. They delayed intubation for 6 minutes or 3 cycles. They got an IV or an IO and gave epinephrine early. Now they also gave epinephrine a little more frequently than we did, but I think the reason I haven't adopted that is there's some other literature suggesting that doesn't really make a difference. Now, I want to talk a little bit about the way they did passive oxygenation. So this study said do not intubate for 6 cycles. The people in the study, the firefighters and medics, initially had a fair amount of resistance to this concept of a non-rebreather. Perhaps you had some resistance to this and said, you know, somebody's smoking some crack here. The concept of a non-rebreather, this just doesn't work, we got to ventilate. So they got a fair amount of pushback. So the way they did this is they said, early on in this study, you have an option. What you cannot do is intubate, but you have an option of doing passive oxygenation versus BVM only. And this study includes all of those together. So what this study is looking at is the entire concept, a bundle of care. 200 compressions, shock, 200 compressions, delayed intubation, early epinephrine. A subsequent paper looked at just the difference between passive oxygenation and bag valve mask ventilation, and we'll talk about that in a second. All right, so their population was all adult cardiac arrest, adult defined as greater than 18 years old, all rhythms, witnessed and unwitnessed. So this is all comers. If you did CPR and on an adult, it was included in here. And I take that back, I'm sorry, it was all medical rhythms, so they excluded trauma. And the reason for that is because almost everybody knows CPR does not work in trauma patients. So these were just medical patients. The other thing to know about this is there was no therapeutic hypothermia done either in the field or in the hospital during the period of this trial. So there's no hypothermia. There's some pretty good evidence that hypothermia increases neurologic survival, so what we can assume is that their results would have been even better had they been doing therapeutic hypothermia. So that was the process. What were their results? And I'm going to sum the results. They have lots of different things here, lots of graphs, but I want to get right to the meat of the results. They measured survival to discharge. So did you get up and walk out of the hospital? And they did it in patients who, the before group, doing typical AHA 32 CPR, and the after group. The survival to hospital discharge in the before group was 1.8%. That's pretty bad. The survival rate afterwards was 5.4%. Now, that is statistically significant, and this paper actually did the right thing by not reporting p-values, and trust me, you don't want to know why that is. They report something called an odds ratio. An odds ratio of above 1 supports your hypothesis that this is better. Their odds ratio was 3, and they had a confidence interval, which means the lowest that could be and the highest it could be, from 1.1 to 8.9. And basically you want a confidence interval that doesn't cross 1. That's kind of the nuts of that. So all comers, VFib, asystole, everything, unwitnessed, 1.8 to 5.4, that is a statistical improvement. They also looked at VFib, witnessed VFib arrest. So these are the ones, when you look at systems that brag about their cardiac arrest survival rate, they're bragging about their witnessed VF arrest, or their witnessed VF survival rate. Before 4.7%, it increased to 18%. So that had an odds ratio of 8.6, and let's just say that's good. So their confidence interval is 1.8 to 42. So that's much better. 8.6 is a very healthy odds ratio. So they almost tripled, actually they more than tripled their survival using this package. So that is a very good thing. Now, one other point I want to make about this study is they also measured the difference in ROSC, and so return of spontaneous circulation, and the difference in survival to ER. A lot of things, a lot of EMS systems historically have measured their cardiac arrest survival rate. Their endpoint was, did we get pulses back, or did we get into the hospital with a pulse? And they said, hey, if we did our part. This is great, let's keep doing that. There are a variety of reasons why that's not the interval we want, the outcome we want. We don't want to create a system that increases the vegetative patients in a nursing home. It's not fair to the patient, it's not fair to the family, it's not fair to society. It's just a bad thing overall. What we want is to create a system that gets people out of the hospital, back to work, neurologically intact, back to their families. So this, before and after, we implemented this process. It increased by more than threefold meaningful survival. Was there a difference in return of spontaneous circulation? No. No difference in how many patients got a pulse back before and after implementation of this version of PICCREW. Was there an increase in survival to the emergency department? No. So implementing this package did not increase either the return of spontaneous circulation or admission to the emergency department. What it did do, however, was increase the thing we care about, people leaving the hospital alive. And the reason I'm trying to stress this is to understand why that's the outcome we care about. If you look at, there was a really nice study done in Australia that looked at the use of epinephrine. Epinephrine in cardiac arrest increased the rate of ROSC. That's crystal clear. It increases the percent of patients we get pulses back. It actually decreased the meaningful outcome of neurologic survival. So I realize that may make you scratch your head a little bit, and you can tell it made me scratch my head to the point that I lost a lot of hair up there. It seems like epinephrine is preventing us from, or is helping us weed out some patients, if you will. The patients that are going to get a pulse back but not survive. Those are the patients epinephrine is increasing. So the bottom line is that we don't care about ROSC. What we care about is getting out of the hospital neurologically intact. Now, we also know that if you don't get ROSC back in the field, they're not going to leave the hospital neurologically intact. That's fairly clear. The rate of survival, neurologically intact survival, without field ROSC is less than 1%, 0.6% in one trial. That's very, very bad. So we want to do everything we can to maximize their chances of walking out of the hospital alive. And this package, this pit crew package, does that. So that is the first paper I wanted to talk about, the minimally interrupted cardiac resuscitation, MICR, by EMS personnel in out-of-hospital cardiac arrest. So that's a Bobro's paper in JAMA. All right. So the last paper we talked about said that this concept of minimally interrupted cardiac resuscitation, MICR, or cardiocerebral resuscitation, improves meaningful survival overall. So that's a very good thing. The researchers also wanted to know, well, does it improve survival in all ages or just some? So they actually did this study again. Actually, they didn't do it again. They used the same data. And then they looked at survival at different age ranges. And remember, this is only adults. So there's another paper called Cardiocerebral Resuscitation is Associated with Improved Survival and Neurologic Outcome from Out-of-Hospital Cardiac Arrest in Elders. And I think the title alone, they clearly went to the right school of learning how to write a title paper, and that pretty well covers the paper. So it did increase neurologic survival in elders, so that's a good thing. And they actually looked at patients over 80 years old. I'm not going to go into the statistics of that because that's kind of boring, but it works at all age ranges. Next, I want to talk about this concept of passive oxygenation. I said in that initial trial, they left it up to the medic's discretion whether they wanted to use passive oxygenation or bag valve mask ventilation as part of their pit crew approach. So the success they had was regardless of which one of those two they did. So that's the entire bundle. Then they wanted to say, well, what impact does just this part, the choice of how to oxygenate or ventilate, make in overall success? So this paper, again by the same authors, Dr. Bobro and his colleagues, is entitled Passive Oxygenation Insufflation is Superior to Bag Valve Mask Ventilation for Witnessed Ventricular Fibrillation Out of Hospital Cardiac Arrest. Dr. Bobro also going to the school of say what you want to say in the title. This was published in Annals of Emergency Medicine in November of 2009. So this was a retrospective analysis of this state database. This it's called the SHARES database, and this is where they tracked all of the data from this trial. So now they've gone back and looked at different components of it. And they also added a little bit more data. So this is from January 1st, 2005 to September 28th of 2008. And they looked at only those patients that received MICR. So they got the pit crew. So the other trial was a before and after. So they excluded all of the before. These are only patients who got the full meal deal, the full pit crew CPR. And now they broke that group into two groups. The group that got passive oxygenation with oral pharyngeal and non-rebreather, and another group that got bag valve mask ventilation. Now again, the difference between the two, it was entirely up to medic discretion. One of the things that they did see is the further along in the trial they got, the more patients were getting passive oxygenation and fewer patients were getting bag valve mask ventilation. So there is a potential confounder here in that perhaps something else was changing. Perhaps something else was different between these two groups, the passive oxygenation group and the bag valve mask group. So they did something called a logistic regression where they went in and they controlled for all the variables. I'm not going to bore you with the stats of that, but they did an this adjustment, and it turns out the two groups were very, very similar. In other words, from a statistical standpoint, those variables did not account for the results. So really it's a pretty clean look between passive oxygenation and BVM early on in cardiac arrest. So again, this is no intubation for a full 6 minutes. The question is, what do we do in those 6 minutes? Two groups, passive oxygenation, the other group is ventilation. So how many did we come out with? So there were 459 in the non-rebreather group, 560 in the BVM group. And again, they looked at all of the other variables. Age, were there more patients that had a witness to rest in one group than the other? No. Were there younger patients in one group, older in another? No. These were equivalent groups. And what they found is in patients with witnessed VF arrest, in other words, we're going to cherry pick the data and look for those patients most likely to survive, that got non-rebreather versus bag valve mask, there was an increase in neurologic survival from 25.8% in the BVM group to 38.2% in the non-rebreather group. That is a statistical difference. The odds ratio is 2.5. The confidence interval, it's 1.3 to 4.6. So a relatively tight confidence interval around the odds ratio of 2.5. Now, they also noticed that there was no difference in unwitnessed arrest. So what that tells us is the baseline assumption we have to make, that we have to convince ourselves before implementing a new thing, in this case the passive oxygenation, is that the new thing is at least equivalent and not worse than the old thing. So they found in all groups that there was no difference between there was no harm in doing passive oxygenation. So what we thought, without understanding the science, and the people who are reluctant to do bag valve mask or do passive oxygenation and stuck with BVM, was there's no way patients are going to do better if we don't ventilate them. We have to ventilate them. If we don't, this non-rebreather thing, A, it makes us look stupid, and B, the patients are going to do much worse. Not true in any population of patients. At worst, in unwitnessed arrest, there was no difference. So we've met our equivalence. We can say that it's no worse than anything else, and we know that it's certainly simpler, and that it decreases the distractions to do the thing that is important, the uninterrupted compressions and defibrillation. However, in the patients that are most likely to survive if we do our job right, the witnessed VF patients, doing passive oxygenation statistically increased their chance for leaving the hospital neurologically intact. So it is in anybody, it is no worse, and in the patients that are most likely to benefit, they benefit well. So there is a statistical increase in survival. So bottom line, passive oxygenation, for the reasons we talked about, works. We have a pretty solid paper here saying it works. And I think that sums up the literature that I wanted to talk about. If there is anyone still breathing on their own out there that's not comatose, if you have any questions about the statistics, if you want a copy of the articles, drop me or Captain Cohen an email and we'll be happy to get you a PDF of the file. It's actually very interesting stuff. I think that we are going to see what we're doing now, which is a reflection of what they're doing in Arizona. I think we're going to see that adopted as the standard American Heart Association ACLS approach to CPR, hopefully with the next revision. I think the literature is definitely supportive, and I think it's time to do it. So what we're doing right now may be looked at as way out there on the edge. It turns out we have great literature to support what we're doing, and I think it's going to be standard of care with the next revision. Not, let me be clear, let's say this, not that AHA and ACLS is standard of care, because it's not, but I think it's clearly going to be adopted as the AHA guidelines with the next revision. So again, I wanted to talk to you about our approach to, our pit crew approach to CPR, the reasons we're doing this cardiocerebral resuscitation or minimally interrupted cardiac resuscitation, and give you some understanding of the whys behind it, the theory behind it, and the science behind it. If you're still awake at this point, I thank you for your attention, and again, if you have any questions, please give me a call. You can also drop me an email, and one last plead, if you have any suggestions for future topics, please let me know, and we'll be happy to work on that. Thanks for your attention, y'all.